We shall now go on to our first speaker, Dr. SUBHRA GOSWAMI, who's the Managing Director of the Nalbari Eye Hospital and Site First from Guwahati. And he has a very interesting video to showcase to us. On to you, Dr. SUBHRA.
I'll be sharing the video, Dr.
Yes, you'll be sharing the video. Yeah.
Start, Dr. SUBHRA. You're muted, sir. Dr. SUBHRA, you're muted.
Dr. SUBHRA, I think you're muted. Yes.
Shall I share the video, sir?
Yes. Yeah, please share the video, please. So this is a rock hard cataract without having any cortical cushion. We'll do phacoemulsification with a different technique. This viscoelastic we are injecting. Now we'll do the axis with slightly bigger in size, such that we can reduce the stress on the granule. Just doing the hydro, but here we are doing a hydro. See the blackness of the whole nucleus. Now we are not doing much rotation because that might give the stress on the granule. So now we are doing a crater. We are trying to reduce the size of the nucleus from grade 6 to grade 3. We are just doing a crater. Central part of the nucleus we are just reducing the size. Separating the very hard, thick nucleus. We are giving very care for reducing the stress on the granule and removing the hard, very hard, leathery nuclear part. See again the blackness, the hardness and leathery nucleus. Care has been taken to reduce the chatter of the inside the AC, because this sharp nuclear pieces might hit the posterior capsule. Then the cortical matter being removed. This is nothing new. Just enlarging the main port. And injecting a acrysoft single piece IOL. Nothing new now. The whole idea of this surgical procedure is to reduce the stress on the granule, number one. Number two, to reduce the size of the nucleus such that we can use less power and it is for nuclear separation. We are injecting Vigamox intracameral. Routinely we are doing. Air bubble size is slightly bigger, that's why we are just removing the air bubble size and finishing the surgery with 6/6 vision next day. Thank you very much.
Thank you very much, doctor. That was a challenging surgery we have shown. I would want to take a question with both Dr. Rohit and Dr. Ramurthy on this. Dr. Rohit, how much of the ultrasound would you want to be torsional, and when would you want the longitudinal component to come for a play in it? And what are your thoughts on creating a crater like he did, or would you want to go ahead and do a chop or quadrant? I know these are all techniques which is each person is comfortable with and would go along with it, but your thoughts on the phaco component of it?
Yeah, I think I would like to congratulate sir for coming out with such an excellent display in such a hard cataract. As we are all aware, as he has rightly said, he made, all the steps were meticulously done. He created a large rexus. He stained the capsule because he didn't want the chopper to hit the, rexus edge and create a situation where there would be an extension to the periphery. Your first question was that
How much of torsional and longitudinal
should be the longitudinal exclusively used? Well, if you want to hold it, then you should be using the longitudinal, because I'm usually I do a direct chop, and when I'm initiating the direct chop, that is the time when I use the longitudinal only. But when the chopping and every other things or the aspiration comes, then I use IP of say 90, wherein the torsional is there, and just to emulsify in a smoother wear, the longitudinal comes into play. His is a beautiful idea of creating a crater in the center because all these nucleus in the hard black cataracts, they are 4.5 to 5 millimeter at times. So you have to debulk them as he rightly did. And I think it was spot on how he did. And smaller pieces, totally separated, replenishing the AC with the viscoat or viscodispersive to come. Yeah, all these points, should be, and he did it meticulously. This is both second part.
Ramurthy, you want to add anything different to what was said?
I think it was a very beautiful demonstration in a tough case, and Rohit mentioned many of the points which come to my mind. I also use only longitudinal phaco for phaco chop during the chopping, because I think that gives me a better hold on the meat of the nucleus. And once it comes to fragment evacuation, I switch over to purely torsional phaco. And even for these hard cataracts, I just use about 70% power with the IP on, which tends to bring the fragments onto the phaco tip in the right manner. He did use a central crater to debulk the nucleus, and which worked very well for him. But I do a slightly different technique in the sense that I use a mini trench right from the rexus margin, the subincisional area, to the center of the nucleus. And this not only reduces the volume of the nucleus, which is less of a importance to me, but gives me access to the meat of the nucleus. In these hard cataracts, it's a good idea to expose your tip a little longer, have a new tip, which is a sharp tip. I'm talking about phaco needle tip, and then bury that adequately. And once I create this small crater, and then I'm able to get better access to the meat of the nucleus, get a firm hold on it, and then come over to phaco position 2 and go ahead and fragment the nucleus and complete the evacuation.
Yeah.
So it is well demonstrated. I think only one other point I would do is, apart from frequent use of dispersive viscoelastic, use the chopper to protect the endothelium from the nuclear fragments which are flying around and hitting the back of the endothelium to the extent possible. And usually it's a good idea to subchop the entire nucleus within the bag. Invariably, when you're removing the nucleus fragments, the fragments do have a tendency to come into the anterior chamber. So generally, I dip it down so that the emulsification is happening at a posterior plane. And I also use the chopper in such a way that the nucleus fragment, which is brought up one by one, has a less of a tendency to come and hit the endothelium.
Yeah. Of course, Ramurthy has also discussed about the tip configuration, and that we need to expose enough of the tip to get a better purchase into the fragment, and also the cutting efficiency of the modern phaco machines. The tips are really remarkable. I want a comment from you, Dr. Rohit, about this dispersive viscoelastic. How you think it could create a wound burn?
Yeah, wound burn, wound burn is only created, when you are starting with these, in the initial stages, when you're using more energy, say, especially in these 2.2 millimeter, incisions. At times, the visco comes and clogs.
Yes.
So you have to irrigate it and you have to gradually get into this thing. So
Yes.
wound burn is something,
Yes.
initial 5, 7, 10 seconds, you have to be very sure, because that is the time when pico burn does occur in these patients, wherein you are trying to use high energy right from the first floor.
It's important that you have adequate flow so that the visco doesn't come and clog the aspiration port.
I just want to make a point here. I use a slightly different technique to avoid this. The sense that dispersive viscoelastic does have is thermogenic, and if you straight away go on to foot position number 3, then that's one situation where you get an wound burn. So usually you're supposed to evacuate a little bit of viscoelastic and then go on with the FICO. I do a slightly modified way of soft shell technique, in the sense that I use a coating of a dispersive viscoelastic on the corneal endothelium, and then subsequently inject a little bit of HPMC in the center, so that when I initiate my initial phaco, it's in a font of HPMC, and the endothelium as such is protected by a coating of the dispersive viscoelastic. And I find that with this slight modification, especially in step 2, when I'm removing hard nuclear cataract pieces, the propensity for wound burn is significantly reduced.
Now, when we are supposing you were to do this in a femto cataract platform, naturally it goes without saying that we need to create more grid pattern and chops and all that has to be done. But there is a lot of cavitation bubbles which also get created. Would you all have a tip for that, so that there is not a experience of a capsule blowout? I know it hardly ever happens, but any tip you would have? Dr. Rohit, you want to say something, Dr. Ramurthy?
Yeah. I think before going into that, whenever my basic concept of, whenever we have had blowout fractures whenever if you go through the literature, those were through only with the posterior polar cataracts. It happened. So those blowout fractures happened with that. My rule of the thumb is that whenever I cannot see the posterior capsule, even when I'm using a retroillumination, I do not do hydrodissection. I believe that all cases wherein you cannot see, you should not do hydrodissection. If you have to do, it should not be a vigorous hydrodissection. So this is something which should be borne in.
Dr. Harshul, you want to add anything here?
No, I think everything has been like said by Dr. Ramamurthy sir and Rohit Prakash sir. Of course, I also use the same technique, drill and chop, which I described in 2010. So basically, I try to create a central hole in which is very deep and which is further away from the rexis, almost 2 millimeter, that hole. So that, of course, as Ramu sir said, we get a good purchase there in the substance of the nucleus, and we also get a proper depth to chop, so that our chop becomes more effective, and it's it's very safe in the center. It's well away from the rexis margin. So that's how you need to do, divide it into smaller pieces and take care that you coat the endothelium well with the dispersive viscoelastic and all those things.
Has any experience, Harshul or Dr. Rohit, have any of you all used MyLoop in these kind of hard cataract when there is also no epinucleus cushion is there? Any idea, anybody?
I never used.
MyLoop is an excellent concept.
Yes.
But I have only one reservation for that.
Yeah.
Because if I have to do in a black cataract, as sir demonstrated, the most important thing is we need to have smaller pieces. With MyLoop, you cannot have more than 4 nuclear fragments. So because a large nuclear fragment, when it comes into the anterior chamber, no doubt as Dr. Ramamurthy sir said, that you use chopper as a shield to protect it from the endothelium. No second thought about it, but still with 4 big nuclear, quadrants, I really do not buy the idea. Till the time we have a provision wherein you can create 6 or 8 nuclear fragments, I would definitely not go in for a MyLoop one. Dr. Ramamurthy sir, your comments on this?
Yeah, I mean, I completely agree with you, Rohit. I mean, frankly, I have no personal experience with the MyLoop, so I cannot really say it's bad. But somehow, when you have access to a good femtosecond platform and modern FICO machines, I really don't know whether it has a huge role to play. And when there is, especially in these very hard cataract cataracts when the capsular bag itself is a little tremulous. There is very little space. At least for the initial few cases, it might be a little difficult to maneuver that. But having said that, there are surgeons who feel that it's a significant addition. But I agree with all the points that you said. And I am sure there will be some youngsters who will be tuning and listening. So just for you to know that, chopping is not the only way to go with these hard cataracts. One of the reasons I do this initial trench from the subincisional area to the center of the nucleus is sometimes the cataract is so hard or leathery that I don't get a through and through chop where the nucleus is split into two complete halves. In that case, after a couple of tries of boring the nucleus and into the nucleus at a deeper level, if I'm not able to chop, I just go ahead and trench that and make it a stop and chop, convert that into a central this thing and create a groove as deeply as possible, then go in with two Sinskey hooks in the depth of the nucleus and just split it up with this lateral separation, causing a minimum amount of stress in the capsular bag. And as regards Chitra's question about the use of the femtosecond platform, only thing you need to remember is that usually with these hard cataract, we use very small cubes, and that creates a lot of pneumodissection and bubble formation. So extra vigorous hydrodissection should be avoided. You press down on the nucleus so that the air bubbles come out, and then give small aliquots of fluids and rotate the nucleus in a more gradual manner.
Thank you very much, Dr. Goswami. That was a wonderful video we saw. Do stay connected.